Today, we are going to take a look at necrotizing fasciitis. Necrotizing fasciitis is a rare soft tissue infection with rapid deterioration that may lead to mortality. There are around 100 cases of necrotizing fasciitis in Canada every year, or 1 in 350,000. While it is rare, it is important to learn about because it can appear similar to a variety of other infections. Severe complications are common, and even with treatment, up to 1 in 3 people who have necrotizing fasciitis will still die.
Infection most commonly occurs when bacteria penetrate in the skin, which is like through a cut, scrape, burn, insect bite, or puncture wound. It tends to develop in people with pre-existing risk factors. These risk factors include chronic diseases such as diabetes, heart disease, renal failure, vascular and liver diseases, as well as alcoholism. Other risk factors include IV drug abuse, steroid medications, chemotherapy, obesity, or malnutrition.
Early recognition is often difficult to achieve because necrotizing fasciitis can have similar presentations to diseases like cellulitis. However, patients with cellulitis tend to be hemodynamically stable. Patients can also be relatively asymptomatic. Early signs of necrotizing fasciitis include soft tissue edema, superficial skin erythema, warmth, ecchymosis, and occasionally a fever. Other symptoms may include extreme tenderness or pain, and eventual progression to hemodynamic instability and tissue necrosis. The most classic symptom is extreme pain that is disproportionate to what you can observe. Diabetic neuropathy and medications such as NSAIDs can mask the pain or even fever. It is vital that nurses know the signs of necrotizing fasciitis because a delay in treatment or being left untreated can lead to amputation, damaged organs, severe sepsis, or even death.
Depending on the causative organism, necrotizing fasciitis is categorized into different types. Type 1 is caused by a mixture of aerobic and anaerobic bacteria and is the most common form. It is often diagnosed in immunocompromised patients, particularly diabetics and patients with peripheral vascular disease. Type 2 is monomicrobial infection caused by a beta hemolytic streptococci, either alone or with Staphylococcus aureus. Type 2 infections tend to occur in otherwise healthy, young, or immunocompromised people. The incidence of community-acquired methicillin-resistant Staphylococcus aureus, known like MRSA, soft tissue infection, appears to be rising. Type 3 is caused by marine organisms. These infections are associated with wound contamination with seawater and seafood ingestion like raw oysters. Type 4 is a fungal infection related to Candida that is rare and mainly affected immunocompromised patients.
Necrotizing fasciitis is a rare but fatal soft tissue infection that initially affects the subcutaneous tissue and fascia without affecting the underlying muscles. The infective organisms can block blood vessels and impact the lymphatic system. This causes thrombosis and vasoconstriction. The decrease in blood flow to the affected area causes severely diminished delivery of oxygen and nutrients. This leads to necrosis in the skin and fascia.
To diagnose necrotizing fasciitis more rapidly and reliably, a clinical scoring model such as the laboratory risk indicator for necrotizing fasciitis is used. This model is based on lab measurements of C-reactive protein, white blood cells count, hemoglobin, sodium, creatinine, and glucose. The total possible score is 13, but if a score equal to or greater than 6 is highly indicative of necrotizing fasciitis. In addition, X-ray, CT scan, or MRI might be useful in case where science or diagnosis are in doubt. Also, additional bedside tests might be done, such as needle aspiration and incision biopsy.
Treatment of necrotizing fasciitis includes broad-spectrum antibiotic therapy, non-viable tissue debridement or extremity amputation, hyperbaric oxygen therapy, and intravenous immunoglobulin as an adjunct therapy, along with split-thickness skin grafts for large wounds. A split-thickness skin graft is skin taken from a donor site and placed on healthy granulation tissue to cover the wound. Hyperbaric oxygen therapy is a treatment that involves a person being in an enclosed chamber while 100% oxygen is pumped in at a high pressure.
It is crucial for nurses to recognize necrotizing fasciitis, especially in patients who are at high risk. In particular, nurses should assess for localized erythema, worms, tenderness to the affected area, skin sclerosis, and signs of sepsis and septic shock, including fever and hemodynamic instability. Nurses who suspect necrotizing fasciitis should promptly notify a provider and prepare for its management. This may include administration of IV antibiotics and fluids. Given the risk for septic shock, the nurse must frequently monitor vital signs and other physical assessment findings for signs of decompensation and immediately notify the healthcare provider. As necrotizing fasciitis is associated with severe pain, nursing care includes frequent pain assessment and appropriate pain management interventions.
So that's the basics of necrotizing fasciitis. Hopefully, you feel better equipped to recognize necrotizing fasciitis in the field and understand how to respond. To test your learning of the different areas we just discussed, learned about, there is a quiz and answer sheet available in the description below.